So let's say that we have a couple nights of short sleep, either from stress or just restricted opportunity. We're really busy, we're up late working on something. When that stressor resolves or when our opportunity increases again, we will have what's called rebound sleep, where the sleep is longer, it's deeper, it's great. And the reason I bring this up is because what a lot of my patients say is they say, I need 8 hours of sleep or I need 9 hours of sleep. And I know that because when I have that night where I sleep those 8 uninterrupted hours, I feel amazing, right? And I say, yeah, that's rebound sleep, right? We all have that. And that's normal. You had that deep sleep and you felt great. But that doesn't mean that that's what you need on a regular basis. And one of the limitations of the wearables is that they tend to reinforce this. So if you have one of these rebound nights, suddenly your sleep score will be excellent. They'll be like, wow, you had an amazing night of sleep. And I think, oh, wow, I'm capable of excellent sleep, right? How can I get excellent sleep every night? But no, 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 that's not excellent sleep. That's rebound sleep. And it feels really great, but that shouldn't be what we're trying to achieve on a nightly basis.
Michelle, I'm so excited to have you on today. And for those of you who have not met Dr. Michelle Jonelis, she is a sleep doctor extraordinaire. She's a neurologist by background as well. I'll let you introduce yourself, Dr. Jonelis. And what we're going to talk about is a really timely and relevant topic given the growing interest in sleep and a lot of the misinformation that's out there. So, can you tell our audience a bit about your background, what you do, and what we're going to cover today?
Yeah. So thanks so much for having me on. My name is Dr. Michelle Jonelis, and I am a sleep medicine physician in just down the street from Dr. Nishi in Marin County. And I also do consulting for Fitbit, but a lot of what I'm talking about today is informed by actually both aspects of my work. So in my sleep clinic, I see mostly insomnia patients. I do see everything. And I have kind of a specialized clinic, which is focused on using behavior and lifestyle change as the primary means to treat sleep disorders. But my main clientele is insomnia patients. And then through the Fitbit work, I'm looking at lots of sleep data from wearables on kind of this large scale. And that perspective of talking to lots of people with insomnia, which actually I've been doing since before my training. At this point, I have like 15 years of insomnia experience, I would say, working with patients, plus many years of personal insomnia experience as somebody who has a history of having had insomnia in the past. So I've thought a lot about this. This is kind of what I do. And with that experience talking to people, plus again, seeing wearable data, which a lot of people don't have access to, the whole picture of, thousands of millions of users and what their sleep actually looks like on a day-to-day basis, it has kind of made me aware that the way we're talking about sleep to the general public might actually be worsening our sleep and creating a lot of unnecessary anxiety about sleep. And so I tried to kind of put together, what is going on, analyze this, how can I get this message across to other people? And so I'm working on that now. And this talk is one, I've given versions of this talk at various places. And I'm always modifying it based on feedback and based on talking to patients. I show these slides that I'm showing you to my patients, right, in real time, sort of get their feedback, learn from them. I bring up this stuff in my consulting job with Fitbit as well. So it's an ever evolving dialogue, and I would love to just throw it out there, discuss it with you. We've never discussed this in particular, and just kind of know what other people think about this, right? Like the more input we have, the better we can do in communicating about sleep so that we're actually helping people and not increasing anxiety.
I've heard a version of this talk before, so I'm really excited to hear the updated one. And I think for you, the clinician who's watching this is definitely a talk to bookmark, and you can use it to have discussions with your own patients in your practice, because some of the points that Dr. Jonelis is going to cover today are really salient, and there's a lot of myths and misinformation out there about sleep. And so this is going to set the record straight for a lot of those things.
Yeah, there's one more thing I'll say, which is actually that one of the final versions of this talk, I don't think there'll ever be a final version, but what it is going to evolve into eventually, I hope, is kind of like an updated CBTI. And I'm hoping to eventually give that at like the Society of Behavioral Sleep Medicine conference in some other places, again, to throw it out there and see what people think. Because I will say that CBTI is a huge part of my practice. I treat insomnia. I know you've talked a lot about CBTI. People who are watching the channel, know about cognitive behavioral therapy for insomnia and how powerful it is. But I will say that since I have started talking about sleep in this way that I'm going to show you in this talk, it really has reduced dramatically the need for CBTI in my patients. Often I can just schedule 1 or 2 sessions to go over all of this. I go over it a little bit at the first visit, depending how long I spend on the history, and then maybe, one follow-up visit where I kind of answer their questions. They try some things, 1 or 2 follow-up visits, and kind of that's it. This is way easier. It's fun. It's easy. It's lightweight. You don't have to get into the nitty-gritty of their psychology or as much, I should say. That's the fun part as well. So we do want to get into that a little bit, but I think it's much more accessible and is easier and really what a lot of people need. So that's kind of where I'm hoping to take this. That's why I would love feedback. I'd love to hear what people think. I'd love you to try doing this with your patients, and eventually I'll formalize it into a protocol. But this is kind of a preliminary proposal.
If you're listening to this talk, if you're watching it, as Dr. Jonelis goes through it, if you have an aha moment where you're like, oh, I didn't think of it that way, or this is something new that I want to start using in my practice, just put that in the comments below because we'd love to hear from you.
Yes, and also feedback. If there's stuff that you don't like, you're like, that doesn't make sense, or that's crazy, or I have evidence to the contrary, absolutely, please put that in the comments. That's what I want. That's what I'm looking for. That's how I make this better. That's how I make it more accessible.
As you can see, there's a lot to learn when it comes to clinical sleep medicine, and we're just scratching the surface in today's interview. If you are a physician or a health practitioner who wants to learn more about clinical sleep medicine in a practical way that you can use in your everyday clinical work, then get my free sleep mini course. I'll put the link to that in the video description below. You can also get it at intrabalance.com/doctors.
So please, please, please feel free to criticize away or challenge me. Misleading messaging is sabotaging sleep. I already told you about myself, so I will skip over that slide. A brief outline, we will talk about current messaging about sleep, kind of how I see that, and then a better way to think about sleep, how to discuss sleep with our patients, and then how we can improve our sleep messaging. Okay, so let's start with this Venn diagram, which I'm going to show you different versions of throughout the talk. And this is a picture of the 3 primary sleep issues in the United States today. So obviously there are lots of sleep disorders. We are sleep specialists. It's a real medical specialty with many different things that we treat, but these are the 3 big ones, okay? And so we have obstructive sleep apnea. You've heard a lot about that on this channel. Insomnia. And for the purposes of this talk, I am defining insomnia as difficulty sleeping despite opportunity. So somebody has the opportunity to sleep, right? They've just finished working. They've maybe done their wind down routine. They close their eyes for the night, but oh my gosh, I can't fall asleep, or I fall asleep fine, but I wake up in the middle of the night, or you wake up too early, or you just kind of have poor quality sleep. You wake up feeling worse than you did when you went to sleep. So that would be insomnia. And then the third is inadequate sleep opportunity or prioritization. So maybe you're working multiple jobs, you only have a 4-hour sleep opportunity each night, or you just don't think sleep is important, right? Yeah, I'll sleep when I die, right? The old fashioned, I'll just work long hours. This is still highly prevalent in the tech world, especially in those people, which is pretty much everybody now who are working on AI. They're being pushed into these long hours again that had fallen out of favor a little bit, and now it's coming back. So this is still very much a real issue as well. I also just want to define this term sleep opportunity because I'm going to be using it a lot in this talk. And this is a newer way of calling something we used to call time in bed. We're just kind of changing the language to sleep opportunity. So sleep opportunity is the time from when you get into bed and you close your eyes with the intention of falling asleep to the final time that you open your eyes in the morning with the intention of getting up in the mornings. And so in that sleep opportunity, there's both sleep and wakefulness, which we'll talk about. So sleep opportunity, it's the same as time in bed. Okay. So let's get into current messaging about sleep that we are all doing. And I am guilty of this as well, right? My background is sleep deprivation research before I even finished my medical school. And with that, the focus was on sleep deprivation and how terrible sleep deprivation was. And we had this view of the world. Again, this is the same Venn diagram, but with different sizes, that the biggest problem that ails Americans today is, or people in the United States, I should say, is inadequate sleep opportunity or prioritization. That if we only understood how important sleep was and dedicated enough time to sleep, we would be healthier. We would have less dementia. We would have less high blood pressure. And the focus of sleep research has largely been on this, right? That hours of sleep matter and they reduced too little sleep is correlated with poor health outcomes. And when that message started coming through, that really dates back to William Dement's book, The Promise of Sleep, that came out, I think, in the 90s. And he sort of opened everyone's eyes to the idea that no, sleep deprivation is a problem, right? Has all of these consequences. And this messaging was really important back then, I would argue. But we've done, it turns out, too good of a job with that messaging to the point where now, you'd have to be living under a rock to not understand that sleep is important and that if you don't get enough sleep, it causes problems. But despite the fact that everybody now knows this, we still treat it as the primary issue. And then insomnia, yes, is acknowledged. There are articles, news articles out there on insomnia and on sleep apnea, but most of the messaging again has this presumption that if we only tried harder to sleep, we only cared more about it, then we would be healthier. In reality, the prevalence of sleep issues is more like this Venn diagram. So, insomnia symptoms, again, inability to sleep despite opportunity, is actually the most prevalent of these three disorders right now. And so, if we are targeting our messaging towards the assumption that if we only tried harder to sleep, if we only dedicated more time to sleep, then we would sleep better, that's not applicable to people with insomnia who are already trying to sleep, right, but are just having difficulty. And so that mismatch between who the messaging is targeted to, nor is that necessarily helpful advice for people with sleep apnea, right, is a problem. So let me give you some statistics to kind of support this thesis. So over 50, this is a quote from the 2023 American Academy of Sleep Medicine Sleep Prioritization Survey. This is a survey that's done every year by the AASM on various topics that covers a wide range of the population. It's thought to be pretty representative of a typical United States population. And so over 50% of Americans on this survey report that they always or often experience sleep disruption due to trouble falling or staying asleep. So 50% of people are reporting some frequency of insomnia symptoms. And I would say this is very true if you just start talking to people. If I talk to somebody, most of the time, they're going to say that they sometimes have difficulty sleeping, or if they don't, their partner does, or their sister does, or their friend does, right? On the same survey, they actually found that 75% of people in the US report using a prescription over-the-counter or herbal sleep aid on an occasional or regular basis, with melatonin and cannabis being the most common. So this is 75% of people, I think this was in the past month, have slept poorly enough or been worried that they would sleep poorly enough in the past month that they are feeling the need to turn to substances. Prevalence of sleep apnea, I'm not going to go into a lot, but basically it depends on the scoring criteria. This is just a Swiss cohort, which is actually much healthier than the US population. And in this Swiss cohort, if we use kind of moderate sleep apnea as our criteria, at least a third, around 40% of that population had sleep apnea by the most common scoring criteria that we use right now. Now let's get into the prevalence of insufficient sleep opportunity or prioritization. I guess we can't know, but insufficient sleep opportunity. People are not dedicating enough time to sleep. The recommendation is that, as it stands right now by the American Academy of Sleep Medicine and other public health organizations, is that adults should sleep 7 or more hours per night on a regular basis to promote optimal health. So we're going to define insufficient sleep opportunity as fewer than 7 hours of sleep per night. And this has been looked at, the proportion of adults who sleep fewer than 7 hours. This has been looked at for years, basically since the 90s when they started looking at this. Actually, we have data going back even further than that. We have these long-term population data. And what that finds is that approximately a third of adults report sleeping fewer than 7 hours per night. Interestingly, if you look at all that data, it hasn't changed. As long as we've been collecting data on this, it's been really stable at a third of adults. And this is just a graph that illustrates this. This one doesn't go back that far, but it does go back 10 years. So the first graph is the prevalence of adults who report sleeping fewer than 7 hours per night. And you can see that over time, it's been stable. These are different surveys. It's been stable at about, a third of the population. If we look at the second graph, which is the percent of adults who feel their sleep duration is inadequate, this is where we see a change. So prior to recently, most people were this green line, which was, do you think the number of hours sleep you get a night is as much sleep as you need? Or do you think you would feel better if you could get more sleep? And so most people felt that they were getting as much sleep as needed. But what we can see is sometime between 2013 and 2023, it crosses over. And currently, more people feel that they would feel better if they got more sleep, even though the actual percentage of people who were getting not enough sleep hasn't changed at all. So our sleep hasn't changed, but our perception of how we sleep has changed. And this is really illustrated in a more recent sleep prioritization survey from 2025 from the AASM, where they asked this great question where they said, how often have you lost sleep at night due to worries about the following? And the biggest thing that people had lost sleep due to worrying about, 78% of respondents, was worries about financial concerns. But just second to that, 76% of respondents reported that they lost sleep due to worries about sleep problems, right? They're not sleeping because they're so worried that they're not going to be able to sleep. Let's summarize this data. About a third of people in the US sleep fewer than 7 hours, a third to 75%, depending on the criteria you use, have sleep apnea. Greater than 50% have some insomnia symptoms. 57 to 76% of adults worry their sleep is insufficient. And then 75% of adults feel compelled to turn to medications to help their sleep. So is our sleep advice, telling people to get more sleep, to prioritize sleep, is it actually helping or is it hurting? People are not getting more sleep, but they're much more worried about their sleep. And so what if the primary problem, which I already posed to you, isn't insufficient sleep duration, but it's actually lifestyle, environmental factors that sabotage our sleep and our expectations for what our sleep should look like? So in my insomnia clinic, I am very convinced that myths about sleep, which are perpetuated by this messaging, perpetuate insomnia. So most of my insomnia patients believe the following things, which are all myths. I don't have time to go into all of them in this talk. That's a topic for another talk, but just take it at face value for now. I could go back and talk about them if there's interest. So 8 hours of sleep is essential for their health. It is not. They believe that nighttime awakenings are abnormal. They are not. They believe that even one night of poor sleep has severe adverse effects. That is not true. And they believe that sleep aids are better than disrupted sleep, right? They know that it's not great to take a sleeping pill. That's another thing where we've been affected. Most people don't think it's great to take a medication for sleep at this point. But they say my sleep is terrible, right? It's better than having disrupted sleep. And it turns out that's not true. That actually really is a topic in and of itself that I can come back and talk on if there's interest. And so what happens is what I call the sleep stress cycle, or those of us in the insomnia field, I didn't come up with this. So there's a stressor that leads to reduced sleep. We'll talk about that. That's actually a normal response to stress that is supposed to be helpful and adaptive. If a lion is coming and killing people in our tribe or a neighboring tribe is attacking, the last thing you want to be is the poor sucker who sleeps too deeply and gets eaten by the lion. So we have this normal response, which we'll talk about, to stress, where our sleep gets lighter, shorter, and there's more wakefulness during the night. That's normal. But because we have told people sleep is so important, even if you get one short night of sleep, you're going to feel terrible. They say, oh my gosh, I can't function on less than 7 hours of sleep. Oh no, that stresses them out more. So not only do they have whatever the stressor is, and that reduces the sleep even more, and this insomnia cycle continues. Fortunately, after lots of practice, talking to other people, hearing how other people talk about sleep, thinking about this a lot, there is a better way to think about sleep. And this is, again, what I want to share with you and get your feedback on. So the way to think about sleep is that it is an automatic bodily function that happens when conditions are right. So the way that we've been talking about sleep kind of makes you think that it's like weightlifting, right? If we just try harder, we lift more weights, then we will sleep better. We can sleep max, if you will. In reality, sleep is more like breathing or body temperature or heart rate. It just kind of happens and it's adaptive to the conditions that feed into that system. Let me break this down a little bit more. So we know, in fact, Dr. Nishi just had something on this. I can't remember if it was an email or what it was, but about sleep efforts. And we know that the harder people try to sleep, actually, the less sleepy they are, right? This is the x-axis is sleep effort, the y-axis is sleepiness. And so when they are worried about their sleep, they're stressed about their sleep, you mount that sleep stress response and the amount that you actually sleep goes down. So you can't just brute force your way. You can't just wish your way to more sleep. It just backfires. And how the sleep actually looks is a byproduct of internal and external factors, and these are some of the most common. So the background, the internal factors are our age, that changes how we sleep. We'll talk about that. And our genetics, there's variability in the population and how we sleep, just like there's variability in how we look. And I would also add to this epigenetics, things that have happened in our past that modify sort of irreversibly or mostly irreversibly the way our body functions. So that's kind of the backdrop. And then on any given night, all of these factors feed into the system and actually affect the depth and duration of the sleep. And that's how long we spend on screens, our breathing airway. Do we have sleep apnea? Our level of stress, substances that we put into our body, medications we put into our body, how much we exercise or lack thereof, how much time we dedicate to sleep, our sleep opportunity, and whether that's matched to when our body thinks is the night, right? If we try to go to sleep during the day, the sleep quality is going to be worse. Hormonal status, very relevant for the perimenopausal, menopausal population right now. Our level of social connection, social isolation, feeling stressed about social or sort of relaxed and happy and connected. Weather, heat, moon phase, these kind of things, inflammation or infections, and diet. There's other things that feed into the system, but these are some of the most common. And so the way to think about sleep is not really like muscle strength, but more like a vital sign. And poor sleep would be more like a fever. This is actually an analogy that I got from Dr. Nishi. And the sleep disruption is a symptom. It's not a diagnosis in and of itself. So if you're sleeping poorly, it's not a sleep problem. It's a symptom. Let's figure out what's causing it. And this is why throwing sedatives or fever reducers at poor sleep will not fix it, because with a fever reducer, let's say that you have a tuberculosis or something like that with chronic infection. You will have intermittent fevers and you may take Tylenol or Motrin for those fevers and they will reduce, but you still have tuberculosis. It's not fixing the infection. And the same thing is true with our sedatives. That's why they're not a great solution, because yes, in the short term, they may either actually improve what the sleep looks like or just make you feel like you slept better, but they're not fixing whatever was causing that sleep disruption in the first place. And so our job as clinicians or as people with sleep disruption is to figure out and address the causes of our poor sleep. And the important thing here is to focus on what we can control versus what we cannot control, and target the messaging to what we can control, not to what we cannot control. So we cannot control how we sleep, right? What the quality. So you say, I need you to get more REM sleep. My wearable says that I'm not getting enough REM sleep. I need you to get more REM sleep. Okay, how can I control that? I can't. How long we sleep, given sufficient sleep opportunity. We'll talk about everybody has an innate sleep need, a sleep set point, right? Mine is about 6.5 hours. If I spend 9 hours in bed for a few nights in a row, I'm not going to be able to sleep 9 hours, right? I'm going to end at 6.5 hours. I cannot make myself sleep any longer. What we can control, if we're fortunate, again, circumstances do play a huge role in how we sleep. And we know there are huge disparities in sleep health because not everybody is fortunate to be able to control these things. But if we can, or if we can help our patients figure out how to have more control over these things, this is where the money is. So we can control our sleep habits, right? what time we choose to go to bed, what time we get up in the morning, and what our bedroom environment looks like, all of these things as much as we can. Our lifestyle habits that feed into the system, and then our attitude towards sleep, worrying about it or choosing to just sort of let it be, understand that it is a vital sign, not something we have direct control over. Each of us, this is one thing that has been really clear to me from my work at Fitbit, looking at this wearable data, is that each person has an innate amount of sleep that they kind of need. And this has been known for a long time. This is not a novel concept, right? That we need different amounts of sleep. Some people are 8-hour sleepers, some people are 6-hour sleepers. But the way that I'm conceptualizing it is a little bit different in that this sleep need is not just a minimum for how much we need, but it's actually a set point. And we'll go through how that is different than sleep need. But genetics, age, and these epigenetics, right, things that affect our DNA, sort of after we're born, that's what determines our set point. And it can change, just like you can analogize this to like your body weight set point, right? Like we have sort of a set point, and then if we eat a lot of ultra processed food and promote insulin resistance, that can kind of change, and it's hard to get it back down. So it can change for sleep, but mostly it stays the same. And our sleep duration or our sleep set point actually declines with age. And this is one of my favorite graphs that I show in most of my talks that I've modified, which has age on the x-axis from age 5 to age 85 in this case. The y-axis is minutes, and this is data from a huge cohort of normal in-lab sleep studies done on thousands of individuals, tens of thousands of individuals in the United States and Europe, where they looked at just healthy research volunteers with no sleep problems, no health problems, and they looked at their sleep study data and how many minutes of each stage of sleep they got at different points across the lifespan. The red that I have highlighted is total minutes of sleep. The blue is that sleep opportunity that we talked about. And what you can see if you look at the blue is that sleep opportunity does decline until we get to maybe our mid 30s, and then it actually stays relatively the same over the lifespan. And this is why you will hear some people say that we don't sleep less as we get older. And that's because they're looking at research from studies, these large cohorts that I've already mentioned where we've been following sleep, where they ask people, what time do you go to bed? What time do you wake up? And then they take sleep duration as the difference between those two numbers. So it's not the way that's called self-reported sleep duration. And that's what's used in a lot of sleep research. And you have to be really careful when you read studies that say things like people with 8 hours have fewer health problems. Those studies are certainly using self-reported sleep duration, the way that I told you, bedtime, wake time, the difference between, right? And that is not the same as the actual minutes of sleep, which if we look at that, it continues to decline linearly throughout the lifespan. And then the stages of sleep also, it's the deep sleep primarily that declines throughout our lifespan. And I have pulled the average durations at 3 different time points below. These durations actually aren't from this data set in the picture. It's a different data set that you can access online and is super cool out of Canada, which also is normative data, again, from in-lab studies. And if we look at this data, again, normal, healthy research volunteers, at age 20, the average duration that people in that cohort are getting is 7.5 hours. It is not 8 hours. That is kind of the middle of this bell-shaped curve, right? 7 hours. That means that 50% of people who are 20 years old, their normal, healthy, well-rested sleep duration is going to be less than 7 hours, 7.2 hours, or whatever I put there, okay? And then 50% are going to be more. By age 50, that's declined to 6.7 hours. By age 80, it's declined points to 6.2 hours. So this is where when we tell people you have to get at least 7 hours of sleep per night, for over 50% of 50-year-olds and 80-year-olds, if they're determining how long they sleep by their wearable data, it's going to be impossible. It's like telling them that they need to be an AI-generated supermodel. It just isn't going to happen. And you can imagine how stressful that is if you're only sleeping 6.5 hours and you think you need 7 hours. And I've already told you that my sleep set point, how much I sleep on average, is 6.5 hours. Interestingly, for my husband, we're both 43. It's the same, right? That is our set point. So if I think that I need 7 hours of sleep per night, that's going to be incredibly aggravating and stressful for me because no matter how much time I spend in bed, how much I increase my sleep opportunity, I'm never going to be able to get to that point for more than a night or two at a time. This is an interesting thing, manipulation that you can make in that cohort that I mentioned, this Canada cohort where you can access the data online. They actually show you something called the first night effect, which is a really great experimental stressor. This is the first night in the sleep laboratory. It's not fun if you have ever done an in-lab sleep study of all these wires. It's uncomfortable, it's stressful, and so people sleep worse the first night that they do a sleep study. And so usually when you report data, normal data from sleep studies, you're looking at the second night or ideally the third night and beyond. And that was the data I just showed you. But if you look at the first night, it's really cool because it gives you a sense of how much sleep on average people get in a stressful situation at these ages. And this is fascinating. I encourage you to play around with it. And if you actually look at the database, it shows you kind of the normal distribution for that. And so it's actually 6.5 hours for somebody who's 20, 6 hours for somebody who's 50, and close to 5.5 hours for somebody who's 80. So this means that if you have your 80-year-old who has had something stressful happen, a stressful conversation or something else, and they tell you, oh my gosh, I only slept 5.5 hours last night, you can say like, oh, that's normal. That's the first night of that, that's just a sleep stress response. It's nothing to worry about. Your brain will self-correct. And so this is just one guideline for how much sleep is recommended at each age. This happens to be from the National Sleep Duration. This graph I actually really liked because they give a range. The blue is like the 25th to 75th percentile recommendation, but they acknowledge that, some people may fall out of that range, which I really like. But in this, they say that this is the amount of sleep that is recommended, right? Hours of sleep at each age. But actually, if we look at the data a little closer and we think about this, you need to think of this as a sleep opportunity recommendation. Again, this is based on self-reported sleep duration, not wearable data, not in-lab sleep data. So when we get to the adults or the older adults, 7 to 9 hours of sleep opportunity is recommended for optimal health, not sleep duration. Sleep duration is likely significantly less, and we are way overdue for an update to these guidelines. I'm hoping by giving these talks that this will be coming soon, but there's a few more steps till we get there. So this recommendation, the 2015 recommendation that I showed you already, adults should sleep 7 or more hours per night on a regular basis to promote optimal health. And we can change to most adults should allow at least 7 hours of sleep opportunity per night on a regular schedule to promote optimal health. Okay, so more on the sleep set point, I just kind of want to explain to you, if I look at my wearable data or you look at your wearable data, what you will see is something like the following, right? So this is the actual hours of sleep. My set point, as I said, is 6.5. In this, it's 7 hours. And then you'll see that on any given night, it kind of fluctuates around the sleep set point. So if I went on vacation, I was outdoors all day. This happened recently. I went to Santa Barbara. I was outdoors all day. I was active. I was at the beach, got a lot of sunshine, a lot of social connection. I didn't use my phone. I left my phone. It was amazing, right? I actually slept more for a few nights. I had like 7.5 hours of sleep for a few nights. But then towards the end of the trip, even, I may be stressed about coming back, but also your body is just like, okay, that was nice, but now I'm recalibrating. So then the sleep duration goes down. And then when I get back, actually, maybe I have a couple nights of 6 hours or even fewer than 6 hours, kind of resetting to that set point. Another way to think about this is that there's also what's called rebound sleep. So let's say that we have a couple nights of short sleep, either from stress, something happened that's really stressful and we're having that sleep stress response, or just restricted opportunity. We're really busy. We're up late working on something. When that stressor resolves or when, our opportunity increases again, we will have what's called rebound sleep, where the sleep is longer, it's deeper, it's great. And the reason I bring this up is because what a lot of my patients say is they say, I need 8 hours of sleep or I need 9 hours of sleep. And I know that because when I have that night where I sleep those 8 uninterrupted hours, I feel amazing, right? And I say, yeah, that's rebound sleep, right? We all have that. And that's normal. And that's because the stressor resolved. You had that deep sleep and you felt great. But that doesn't mean that that's what you need on a regular basis. And one of the limitations of the wearables that I've been trying to correct but have little power over is that they tend to reinforce this. So if you have one of these rebound nights, suddenly your sleep score will be excellent. They'll be like, wow, you had an amazing night of sleep, when it's calibrated so that your typical sleep is like good, right? Like a really great, healthy, normal sleeper, their sleep score is going to be kind of in the good range. That's true for me. But then when I have one of these rebound nights, suddenly it's excellent. And I think, oh, wow, I'm capable of excellent sleep, right? How can I get excellent sleep every night? But no, 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 that's not excellent sleep. That's rebound sleep. And it feels really great, but that shouldn't be what we're trying to achieve on a nightly basis, because it's a biologic impossibility. We cannot achieve it on a nightly basis, right? After the rebound sleep, then you recalibrate back to that set point. Okay. So, shifting gears a little bit, I've come up with another framework that you can kind of go through what I said. This is another way that I talk to patients about sleep that I've really just come up with and have found super useful with the patients that I've used it with recently. And I hope you try it, share it, and let me know what you think. But I say to them in the initial visit, right, I'm showing them these same slides that I'm showing you, pick and choose depending on their needs. But the reason, what I say is, the reason you can't sleep is your brain isn't sleepy enough, right? Like that sounds really overly simplistic, but it's true. You can't sleep in that moment because your brain isn't sleepy. And then I break it down into an acronym. In order to be able to sleep well, we need to be, and I go through the sleepy acronym, and I literally pull up this slide in the visit, go through this, we discuss it, and we figure out what the issue is, which of the inputs is disrupting their sleep, right? So I'll just go through this very briefly. I can do another session on this if you want. But safe, settled, meaning that if their brain feels stressed, they're not going to, I'm just going to go through it on this one. If their brain is stressed, that's going to make the sleep lighter. They're going to have that sleep stress response. If they haven't been awake long enough, then they're not going to be sleepy at night. If they're trying to sleep at the wrong time, they're not entrained to their rhythm, it's going to be hard to fall asleep. If they haven't engaged in activities during the day socially, mentally, physically, then their sleep is going to be disrupted. Practicing healthy habits. This also includes environmental factors like lighting, temperature. That's going to feed into the sleep system. And then your opportunity fits. And this one is huge. It's matching the opportunity for sleep to the sleep need. So like I said, if my sleep duration on average, my set point is 6.5 hours, but I think that I need 8 hours, so I spend 8 or 9 hours sleep opportunity per night, let's say 9 hours, I'm going to have 2.5 hours awake on average during the night. It's going to vary depending on my activities, but approximately. And so I will have all of this wakefulness, and all I need to do to get my sleep back on track is just spend less opportunity for sleep, right? Sleep restriction, which we have talked about, I'm sure, on this channel with CBTI. That's one of the mainstays. So again, I go through that with the patients. I found it super helpful. There's always something in the sleepy, and that's what we focus on. That's why we don't necessarily need full CBTI, or maybe we do, depending on what the issue is. Okay, so how do we discuss all of this with our patients? Or how do we discuss not what I just told you, but sleep in general with patients? And like I said before, we want to focus on what we can control, not what we can't control. And fortunately, there's kind of an easy hack that you can think about that will help you with this distinction. And it comes down to adding one word, which is habits. So sleep is so important for overall health. Healthy sleep habits are so important for overall health, right? Do you see the distinction? I can't control my sleep. I can control my habits. Here's a real example. I have a handout that I'm working on, which I'm hoping that the American College of Lifestyle Medicine, which I'm also a member of, will adopt. I've sent it to them. And so instead of sleep is important, healthy sleep habits are important. So they had this handout on sleep health, and I modified it, tips for better sleep, recommendations for optimal sleep. I changed it to healthy habits create healthy sleep. And then I focus on the habits. So I say sleep is an automatic biological process that occurs when conditions are right. We cannot directly control sleep, but we can control many of the factors that influence it. How we sleep, our duration, depth, and continuity acts like a vital sign, offering insight into our overall health and habits. Healthy sleep and lifestyle habits support healthy sleep. So this is the big take home point when you talk about sleep, when you write about sleep, when you read anything about sleep, think about this, right? Are they talking about things that I can control or that I can't control? And often just adding habits changes that dynamic. When you ask people about their sleep, just try asking like this. Say, did you know that sleep is this amazing vital sign that's a sensitive indicator of our overall health? How do you sleep? Right? Not, did you know that sleep is so important for our overall health? Oh my gosh, I'm so stressed about how I'm not sleeping. Did you know that sleep is this indicator of how we're doing otherwise? How are you sleeping? Oh, I'm not sleeping well. I wonder what else is going on. Again, small, subtle tweak, but I think it makes a huge difference to alleviating sleep anxiety. Okay. And then I also have some stuff on just kind of insomnia inclusive sleep messaging, because remember that the primary issue that your patient is likely to be facing is not insufficient sleep opportunity or prioritization. It is possible. A lot of people still do have that, right? A third of the population potentially. But it is more likely that even if they do have that, they also have some insomnia type symptoms. And so uh, we need to keep that in mind whenever we say anything about sleep. And I firmly believe that truths about sleep, right, instead of myths about sleep, can reduce insomnia. And these are just some of the things that I say. And this is kind of another talk, but sleep is an automatic bodily function that happens when conditions are ripe. I've already told you that. How sleep looks is a byproduct of internal and external factors. Everyone has a unique sleep set point, and 6 to 7 hours of actual sleep per night on average is perfectly healthy for many adults. Wakefulness is a normal, essential, healthy part of sleep. Stress reduces our sleep duration and depth to protect us from threats. There are effective behavioral strategies to manage insomnia, and sleep aids do not improve health, cognition, or daytime function. Again, that last one is a talk in and of itself, but it is true. Okay. And so based on giving this information to my patients, again, really breaking this down as a whole other talk, but this is kind of what I expect to happen. So I showed you that cycle in one of the earlier slides between stress and how that reduces sleep and causes more stress. But so once I have given them this education, this is what happens. So they have some kind of stressor, whatever it is, it reduces their sleep, and they say, "Oh, I understand that stress hyperarousal has reduced my sleep need, my sleep duration. Let me put an action plan into place to help reduce that stress." Hyperarousal is another term for sympathetic nervous system activation that causes the stress response. And that includes writing my worries before bed, reducing my sleep opportunity temporarily, addressing the stressor as able, and daytime stress reduction strategies like mindfulness, exercise, healthy diet, those kind of things. Okay. So thank you all for listening. Again, I really want feedback about all of this. I really want you to share an experiment, try the habits hack, and see what happens. Tell me what you think. Okay.
Fantastic. Thank you, Dr. Jonelis. That was so good. I'm really curious to hear people's aha moments or anything that you felt like, I don't know about that. Tell us in the comments so we can have a discussion about it. Gosh, there's so many things that you said that I think are just like really, really helpful. One is I wanted to highlight the point that you made about sleep being a passive process. We can create the conditions to allow it in, but we can't make it happen. And I think that's really important to talk to people with insomnia about, because they do put in more sleep effort. And you showed us how that can actually backfire and it makes your brain less sleepy. And one of the analogies that I like to use is sleep is like hunger, right? If you're going out for dinner and you're going to a nice restaurant, it doesn't really help to worry about, am I going to be hungry enough for dinner tonight? No, what do? You just eat a lighter lunch. You just don't eat as much, so you're going to be hungrier. And sleep is kind of like that. And I'd like to remind people that we talk about falling asleep. It's like this passive, we fall into it. We can't force it to happen. So I'm curious just to hear your thoughts on how do you talk to patients who are putting in a lot of sleep effort, those patients with chronic insomnia. How do you speak to them about it?
So again, I literally, what I just went through with you, I go through with the patients, right? Not necessarily the whole 40-minute version, but I pick and choose. So I sort of focus on their language. My favorite question on my intake questionnaire is, what's your goal for, oh, sorry. So I say, how much sleep do you think you need? How much sleep do you think you're getting? and then what's your goal for your sleep. And so if their goal is 8 hours of uninterrupted sleep, right, that's my starting point. So I say, oh, did you know that you don't really need 8 hours, right? And that wakefulness is a normal, essential, healthy part of sleep. And I just kind of start there. And I think that they're putting in the effort because they think that they're supposed to be doing this thing, which is actually a biologic impossibility for them. And so that's kind of where I start. So I do talk about sleep effort, we go through that, but I think that just sort of what is their main focus and then kind of dispelling that myth right away is a really helpful
Great.
approach.
Yeah. And I really like the sleepy acronym. I'm going to start using that as well. I love that slide. It's so interesting, too, what you said. Sometimes you don't need to do the full CBTI protocol. And I've certainly seen that in my practice. We even have a group program. And some of our clients in the program will say, I feel better after 2 weeks. They haven't even gone through the
Right,
whole thing. They've just had the
right,
psychoeducation piece by that point, and they're already doing
right.
better.
Yeah, and I think that's true because my impression doing this work is that insomnia really has morphed, right? I mean, it used to be 10% of the population had severe insomnia, maybe 30% had some insomnia type symptoms. So the insomnia that we talked about in the 80s, in the 90s was very different than our modern insomnia. And that's why CBTI works, but it doesn't always work. It's because it's kind of a different beast, right? A lot of the insomnia, it's really just this misunderstanding about thinking that they need 7 hours or 8 hours or whatever. And all you have to do is just convince them that no, they don't need that and they're better, right? And I've had these amazing cases. I had this one woman, sometimes I quote her in talks that I gave her. She said, just the initial visit. And she said, I'm an 8 hour sleeper. I'm an 8 hour sleeper. Right? And then at the end of our visit, after I went through all of this, she said, I think I just need to start thinking of myself as a 6 hour sleeper, that I was an 8 hour sleeper, but now I'm a 6 hour sleeper. And I was like, yes, you're right. This woman was in her 70s and she was like, great. And then she was better. Like we didn't need CBTI. And these are really severe people. Like the people I get in my clinic, they've
Yep.
failed CBTI. They've been on multiple meds. Like these are not just random. Sometimes I get that random person off the street who has only had insomnia for 2 weeks. And I'm like, oh, I love you. But these are like real severe insomnia patients. And sometimes that's all it takes. It's just one visit or two visits. So I think, again, those more classic insomnia patients do exist, but it's a smaller portion of that
Yeah.
50%.
Yeah. No, that's really interesting. And one of the other ways that I conceptualize chronic insomnia, like when it's its own self-perpetuating thing, you highlighted that statistic from the ASM
Yeah.
survey about, what was it, 76% of people,
76% of people lose
right,
sleep due to worries
they're
about
losing sleep over
sleep.
their sleep. And like one conceptualization I have around that is it almost becomes a phobia of being awake at night. And so a lot of the work that we do in our practice, and like you and I have a very similar practice style, so I'm sure you're doing
Yeah, yeah,
something
yeah.
very similar where we're kind of trying to deactivate that fear that comes up around being awake at night. It's okay. It's normal to have awakenings at night. So I'd love to hear your thoughts on how you approach those patients who say they wake up at 3 a.m. and they can't get back to sleep. Now they're awake for hours and, there's hyperarousal maybe, or they might say, I don't even feel anxious. I'm just awake. How are you navigating that in your practice?
Yeah, so this is where I love that sleepy acronym. Try it. Just pull up that slide and go through it. So we just, okay, let's go through. Let's see. This is really interesting. Let's go through the acronym and see. Is it temperature? Ooh, your temperature is, 80 degrees at night. Let's try fixing that and see. Alcohol, you're having alcohol. That would be under the, healthy habits. Let's try stopping alcohol. Oh, your sleep opportunity. That's going to be a sleep opportunity issue, right? For sure. Yeah, and I show them the data, that normative data that I showed you, and I say, let's just try reducing the sleep opportunity. And the thing is, with reducing the sleep opportunity, that's the hardest part of CBTI, right? Anybody who does CBTI will tell you, how do you convince patients to spend less time in bed? That's like our, CPAP salesperson, right? As sleep apnea physicians, we have to sell the CPAP, right? Or we get really good at that. And that's the shoe salesman person aspect of CBTI. But I'll tell you that when I explain it to them, as I just did, and I say, we're going to recalibrate your sleep. Like we need to have less sleep opportunity to recalibrate. I don't actually even talk about the long term. I just say you need to reduce your sleep opportunity to recalibrate your system, and then we'll figure it out from there. They're much more likely to jump in. Like I don't have the same kind of resistance that I used to have with classic CBTI, where it took me session after session after session just to even get them to go below 8 hours of sleep opportunity, right? I don't run into that. These patients are on their own, sometimes doing like a 6.5 hour sleep opportunity. So I think that when you kind of go into it, that's interesting, right? Non-judgmental, and let's recalibrate the system. We got to do these factors. Let's stop the alcohol. Let's do this. We're just going to recalibrate things and keep it very short term rather than long term. Just we'll get to the long term eventually. I think it's really helpful.
That's
Yeah.
such a great acronym again. Yeah. So I recommend if you're watching this, you can replay this video even for your patients. Like you can take sections of it and show it to them in clinic or just pull up the slides. The other thing I thought was really helpful that you shared was about the rebound sleep and how that can impact sleep scores on the wearables, Fitbit or Oura Ring or whatever people are using. And I even see this in physician Facebook groups where physicians are worried about their
Yeah.
sleep score and their percentage of REM sleep and deep sleep and all of these things. You do a lot of work with Fitbit. Is there anything else any take-home messages you want to emphasize here?
I know. So before I was working for a wearable company, actually, I've been consulting for wearables for a while now. I started doing this work, I don't know, 2018, 2019 for various companies. But my early perspective, even when I was doing consulting, was basically who needs these things, right? Like, I know if I slept well or not. I know what I need to do to get my sleep much higher, but I don't need the wearable to tell me. But I will say that for the most recent projects that I've been doing, as part of my job, I've worn my own wearable like every night before. I just didn't used to wear it regularly because, again, who needs it? But in wearing it regularly, I think it's been really a really interesting experience in that some of these nights where I have more wakefulness during the night, like I didn't realize what it was until I understood this concept. I didn't worry about it because I got over that years ago. That was part of my insomnia recovery. But with the sleep set point concept, I understand like I had a bunch of longer nights and now it's just this recalibration. And, with the stages of sleep, I think if it's outside, the wearables should be all giving normative ranges. That's one thing we're working on. Like, and usually you can't just, if it says you have 15% REM sleep and you're, 70 years old, that could be normal. That could be like within the 25th to 75th percentile. And even if it's, let's say it's the 5th percentile, still, like I'm short, I'm 5'1". I don't know what percentile that is, but some people are going to fall out of that. So it could be normal. I think if it's, you always want to compare to the normative values that are normed for your age and gender and even location, right? So you have to compare it to that. And if you are comparing it to that and it's outside of like the 25th to 75th percentile, then you can use it as like, is there something I'm doing? Like I did an experiment once because patients would tell me an eye mask and earplugs like fixed all their problems or these sleep masks. So I've done those kind of experiments with my wearable where I'm like, I'm going to wear an eye mask, every night for a month and see what happens. Did nothing for me because my room was already very dark, right? So what's the eye mask doing? But I do use it sometimes if there's like a full moon. But I think, you think, can it change or stopping alcohol? Like it's this kind of cool thing where you can actually do these experiments in real life, look at the sleep, see how it affects it. But that's just how you have to look at it. Like, that's interesting. And the wearable makers, PSA for anyone who works for a wearable, should not be rewarding rebound sleep. This is a huge issue that I've been trying. Like I said, I'm very low level at Fitbit. I don't have control over these things, right? There's certain things I have control over. I don't really have control over anything. I do what they tell me to do. And I give input, where I'm asked for it, basically. But I'm trying to say, and for all the companies, there's an issue. This is not an excellent sleep. This is rebound sleep, right? What it should say is your sleep is typical for you, typical for your demographic, right? And then this was atypical due to being longer and deeper, atypical to being to shorter and lighter. And if it was atypical, let's say it was shorter and lighter, maybe you're stressed. What could that be? That could be stress. That could be reduced sleep opportunity. It could be some kind of environmental disruption. These are the things. And if there wasn't any of these, maybe it could be recalibrating to the set point, right? So I do think it can be useful to track your sleep, but more as a curious scientist rather than a stressed insomniac, right? And you can move from one to the other. I made that transition, right? So I think it's not to say that it's not useful. And it's super useful from a research perspective. Like we have data. I mean, we're using wearable data. We are able to visualize sleep in a way that has never been possible. A super extensive sleep study, maybe you would have 1,000, maybe there's some where it's like 10,000 participants with one night of PSG and like 1 week of actigraphy every year, right? Like that would be a super elaborate, super extensive sleep cohort. Now you have millions of users for like years at a time. I mean, it's unbelievable. So we we have to use this. We have to jump on this. We have to publish it. Like, we have to work as sleep researchers. We have to work with the wearable community and really mine and harvest this data to understand sleep in ways we never have before. I mean, it's incredibly powerful, and that's super exciting. So that's the other reason I want people to use their wearables, is just so we can figure out what normal sleep actually looks like and make better recommendations. So
Well,
yeah.
this was a fantastic talk, Dr. Jonelis. Thank you so much for coming on. I'd love to have you come back and talk about sleep aids. You mentioned that a couple times, like that could be a whole talk in itself. And
Yeah,
we
it
can
is.
definitely, look at doing something like that. And maybe even another discussion on wearables, because that's also another big topic and more people are
Yeah, yeah,
using
yeah.
them. If you are a clinician and you're watching this video and you found this helpful, go ahead and click the like button so that we know we're on the right track with providing information that is useful to you. And Dr. Jonelis, if people want to work with you, where can they find you?
I have a personal website, Jonelis MD, and then my practice is called Lifestyle Sleep, Healthy Life, Healthy Sleep. And so you can find me through any of those ways. And I do also publish some articles on Substack and on Medium. I just put them on both forums, so you can look for those as well. And I would be very, like I said, I want feedback. I want to be challenged. The more engagement, the better we are at what we do. So please comment and get in touch with me and whatever you need. I'm here for you.
Amazing. We'll put all of those links in the video description below.